Welcome to Class 3 of Kinesiology 3500, Drugs and Athletics. We're going to be covering narcotics, nonsteroidal anti-inflammatory drugs, and masking agents and diuretics. These correspond to Chapters 14, Chapters 19, and Chapter 9 of the 6th edition of Drugs in Sport by David Mottram. By the way, there are two reference copies available for 2-hour checkout at the Stanislaus State Library for those of you who do need to take a look at the text and don't have it. The text is a very important part of this course. It's used in our tests and examinations and should be applied to your assignments, and all the quizzes do have information that draws from our text. Please also be checking your Stanislaus State University email on a daily basis throughout the semester for any important announcements in this course, as well as logging onto Blackboard on a regular basis to find out the due dates of your assignments and exams, and to stay on top of the course. So if you play a sport at any level long enough, whether it's a contact sport or a non-contact sport, you're going to experience some level of pain. Real or perceived injuries can keep an athlete from playing at an optimal level. Pain is a cardinal sign of an injury, and inflammation is a key response to sports injuries. Pain is a protective mechanism of the body, and it's a subjective measure based on one's perception of pain. It can depend on many different factors beyond the actual severity of the injury. It's difficult to measure, but it's not to be ignored in an athlete. We're now going to take a look at a film on the inflammatory response.
We've all had cuts on our finger or wherever else on our body, and immediately that part of the body that gets a little bit of redness, a little bit of swelling, some heat maybe, and of course there'll be some pain associated with what's going on there. And in general, this set of symptoms that we experience, these are known as the inflammatory response, or you might say that there's some inflammation going on there. And people have known about this, I guess, ever since really people have been having cuts. They've probably, with modern medicine, have people been a little bit more particular about actually classifying the symptoms. But this isn't anything new for someone to say that there's some type of inflammation going on or some type of inflammatory response. But what I want to do in this video is understand what's causing these, I guess we could call them macro symptoms, what's happening at a cellular level. Because really, inflammatory response is essentially the initial field of battle of our immune system. You know, our first line of defense is our skin, or the fluids on the outside of our skin, or the mucous membranes. But the inflammatory response is what happens when something gets beyond that. We get punctured with a nail, or there's some type of virus or bacteria gets beyond our skin, or the mucus that surrounds our membranes. So let me use battle. This is the field of battle. Field of battle, especially the initial field of battle. So let's set up an immune battle so we can see exactly what's going on with the inflammatory response. And I want to be very clear. Immunology, people, it's still a very understood field. It's an area of active research. People are still discovering the mechanisms, and it's hugely complex. I'm sure we'll probably be studying this for a long time to come. So what I'm going to talk about is just the overview, just so you know the general actors, and you know in general what's causing the redness, the swelling, the heat, and the pain. So let me draw some skin cells. So let's say that these are skin cells. This is a gross oversimplification of everything, but it's really just to give an idea of what is going on. So I'm going to do a cross section. So those are some skin cells in there. And then I'm going to, so this is the outside world right here. Outside world. And then amongst those skin cells, I'll do some other cells, and we'll talk about what they do. I won't go into huge detail about them. Let's call this cell right here, let's call this a mast cell. I'll draw a few more mast cells. Maybe another one right there. That's a mast cell. And if you remember from the videos on phagocytic action or phagocytes, you remember there's one type called dendritic cells, and they tend to hang out near our skin. They kind of hang out near areas that might interface with the outside world. So I'll draw a couple of dendritic cells. And these were also the ones that were really good at activating, so this is dendritic, at activating helper T cells. Dendritic. Maybe I'll do one more dendritic cell right here. Right there, that's a dendritic cell. And they're called dendritic cells. They have no relation to the nervous system. They just look like they have dendrites on them, and that's why they call them dendritic. But they're really phagocytes, and they tend to be near external interfaces, and they phagocytose particles, and they're good at presenting them to helper T cells so that they can get activated and ring the alarm bell, so to speak. So this is just a normal, functioning, happy skin. So that's the outside. Over here, this is the interstitial fluid. Interstitial fluid. That's just a fancy word for the fluid that cells are kind of being surrounded by, or that bathes cells. You know, the cells aren't all directly connected to the circulatory system. The oxygen goes from the circulatory system to the interstitial fluid and eventually finds its way into cells. So it's not, you know, everything is directly connected to capillaries, but capillaries play a big role, our circulatory system. So let me draw that. Instead of just drawing them as tubes, I'm actually going to draw the cells of our circulatory system. So let's say that this down here, these are the endothelial cells of our capillaries. So these are literally the cells that make up the walls of our capillaries. Right there. Let's say that's one side, and let me draw the bottom side right here. These are the actual cells, and of course this is a cross section. If I were to, you know, I would draw it as a tube somehow. This isn't, it's not like it's a sandwich, it's actually a tube. And obviously everything is in cross section. So these are endothelial, spelling is the hardest part. Endothelial capillary, or may I say capillary endothelial cells. And of course, right in here, this is what we have our blood flowing, and we'll have red blood cells in here. Maybe I'll draw a couple of red blood cells in here. These are red blood cells. Maybe they're flowing in that direction. On this side, they're oxygenated. This would be arteries, and then they become veins as the red blood cells lose their oxygen. And of course, you might have circulating white blood cells inside of your, obviously in much lower quantity than your red blood cells, but just to show that they're circulating and they're moving with your circulatory system being pumped by the heart. Now, under normal circumstances, there is an exchange of, obviously, of gases between what's going on in our circulatory system and the interstitial fluid. And there's also a mild exchange of some cells and proteins. But what we're going to see now is what happens when we have an intruder. So let's say someone takes a nail, dips it in some cow manure, and then pokes you with that nail. So let's see what happens. So someone pokes with a, you know, it's a big nail. You know, these cells are. So let's say someone pokes you with this nail, dipped in cow manure, so it's got all sorts of nasty stuff on it, pathogens on it. Probably has a bunch of bacteria sitting in the cow manure. I didn't pick cow manure at random. It's probably a good source of bacteria. So as soon as it pierces the first line of defense, as soon as it pierces your skin, a couple of things are going to happen. A lot of these bacteria are immediately going to start floating around in your interstitial fluid. The cells that it came in contact with, it pierced them. It probably killed some cells. It's also going to damage some of these skin cells. And those skin cells are immediately going to start releasing chemicals, the ones that are still in a position to do so. They're going to start releasing chemicals that are essentially chemical messengers that move through the, well, at first locally in the interstitial fluid, and says something is going on. Something has, you know, happened to me. And these are called chemokines. Chemokines. And chemokines are just a very general word, really, for small molecules or small proteins that cells release as a kind of signaling mechanism. Chemo for chemical, kine for kinetic, for moving. These are messengers. They move. So these chemokines get released. And this is all tremendously complicated, so I'm doing a very high level. There are many, many types of chemokines. And also you have these mast cells here, and these mast cells can be activated by direct contact, maybe with the rusty nail. It could be from the chemokines released by some of these cells up here. It could be from some of the molecules released by the actual bacteria. These bacteria are also releasing, you know, different byproducts as they enter the body. And any of the above can activate the mast cells, and mast cells release histamine. Histamine. So the mast cells release histamine. So I'll do that in that color. Histamine. So you can already appreciate I'm doing a high-level overview, and it already is kind of complicated, but I think you get the sense of what's going on. And if the word histamine sounds vaguely familiar, it's probably because you've taken an antihistamine sometime, probably in the last several months, if especially during cold season. Histamine is what is kind of one of the main actors in the inflammatory response. And when you have a cold and a runny nose and stuffy nose and all of those type of things, those are all byproducts of the inflammatory response. And antihistamines essentially try to shut down that inflammatory response, so some of those symptoms disappear. But it begs the question of, is that necessarily always a good thing? Because, as I'm going to talk about in this video, this is the first line of defense. This is the first part of the battle of our immune system. But anyway, so the histamine, one of the things that the histamine does is it goes to the endothelial cells that line your capillaries, and it causes them to separate away from each other and make the actual capillaries larger. This is called vasodilation. So let me erase some of these and make them get larger and make the area. Let me make it the area larger. So let me erase these. Let's say that histamine, they've all been activated with a little bit of histamine. So let me go back. Okay, so then the histamine has come in, so now these guys get further apart. They get further apart, and the actual capillary becomes larger. So there you go, and then on this side it's also going to happen. So this is where you get a lot of your swelling, because all of a sudden the capillary is larger, more fluid, and actually it gets smaller further down, so it encourages the fluid to collect right around here. So this is called vasodilation. Just another fancy word for saying your capillaries are getting dilated, or they're getting larger, or fluid is filling them up. And not only are things starting to collect here, more and more red blood cells are collecting here. Obviously there's a lot of fluid here, the white blood cells, but also the capillary walls are becoming more porous. All of a sudden, things that couldn't get through them are going to have a much easier time getting through them. And one of those things that they're going to have an easier time getting through them. And once again, remember, all this other stuff is going on. You have these histamines that are, being dumped on these endothelial cells, and maybe some of it's getting into the serum. You have these chemokines. You have these chemokines being released locally from this area of damage. You have the actual things being, the green was the color of the molecules being released by the viruses. You have the chemokines, which are in blue. They're all being released here. And your first and so the first responders, which we talked about, the phagocytes, and in particular the neutrophils, which are the most abundant of the phagocytes, a subclass of white blood cells, they're attracted to these chemicals. They're attracted. They want to move in the direction that there's more of these chemicals. And now that the space between these capillary cells have gotten further apart, they can get through. So what they actually do is, let's say that this right here is a neutrophil. This right here is a neutrophil. They start kind of rolling along the wall right here. That's called marginization. They roll along this wall, and eventually, so they kind of stick to the wall, they adhere to the wall, and then eventually they squeeze through. They squeeze through these gaps in the capillary wall. This is called diapedesis or extravasation. Sometimes it's called emigration. These are all fancy words, but essentially it's just squeezing through the wall. So that's the neutrophil right there. And then, of course, because of the vasodilation, this is where the neutrophils will be getting dumped in, and this is exactly where they're needed. So these neutrophils are going to be here, and then they're going to do what they do. They're going to phagocytose some of these bacteria and start eating up, and maybe even some damaged cells up here. And so that's what you want to happen. That's why I said this is the field of battle. At the same time, your dendritic cells, other phagocytes, they will eat up the viruses, and then they'll present them on their surfaces. And it's not just neutrophils that are coming in, because this is kind of an area of congestion in your all of the fluid is coming here. You'll also have B cells and T cells. They'll also make their way. They'll also experience marginization, where they roll up against the sides of the capillary, and then diapedesis or extravasation, where they go through and then they'll be activated, and they can actually do the specific immune system. So the whole point here is I wanted to show you, and this is why I delayed the whole video on the inflammatory response, because it isn't just some, one type of simple thing. It's actually the field of battle where all of the actors come in play, even the first line of defense of your skin, and then all of the actors, the non-specific reactions of, inflammatory response is normally categorized as non-specific because it's going to happen no matter what comes. But you have the non-specific actors like the neutrophils. You have your specific actors like your B cells and T cells. And you also have the non-specific complement system. And I'm not going to go into detail here, but you actually have proteins that are flowing in your blood plasma that are normally in an inactive state. But when the inflammatory response occurs, these proteins, they get essentially activated, and sometimes, and this is all not 100% well understood, they become activated, they get cleaved up, and then the cleaved up versions of those proteins are really good at, in a very non-specific way, helping to kill off at least some of what's getting, maybe the bacteria in this case. So this right here, this is the complement system, which is really just a set of proteins that always just floats around, and they are good kind of first line of non-specific fight against some type of invading pathogen. So hopefully this gives you a good sense of what is going on in the inflammatory response. And as you can imagine, you have all of this fluid coming here, all of this blood is collecting here. You have all of this fluid coming into, so not just cells that are going from our capillaries into our interstitial fluid. You'll actually have fluid going in, and that fluid that's going in is called exudate. Exudate. So this whole thing becomes swelling and red and engorged, and that's why you see on kind of a very macro level these type of symptoms.
Pain is a fact of sports participation, whether you are in a contact sport or not. Athletes will take their bodies beyond their limits to achieve their goals, and because of that will end up using drugs to address their pain. Anti-inflammatory drugs such as NSAIDs or non-steroidal anti-inflammatory drugs are commonly used. When perhaps more serious injuries are sustained, narcotic analgesic drugs are used, and oftentimes in conjunction with non-steroidal anti-inflammatory drugs. Some of the common non-steroidal anti-inflammatory drugs include aspirin, which was the first discovered non-steroidal anti-inflammatory drug, also known as acetylsalicylic acid. Some of them are found over the counter and can be purchased at your local pharmacy, such as ibuprofen, naproxen, also known as Aleve, aspirin, of course, acetaminophen, also known as Tylenol, diclofenac sodium or Voltaren, which is available via prescription, and Celebrex and Vioxx, which is also available via prescription, also known as a COX-2 inhibitor drug. There really is no known ergogenic effect to use these other than the fact that athletes can use it to address their pain and inflammation and perhaps play as a result of that. Some side effects may include GI bleeding, gastrointestinal bleeding with repetitive and chronic use, and athletes use this to treat joint pain and delayed onset muscle soreness. So we see here, when addressing pain is no longer effective with non-steroidal anti-inflammatory drugs like ibuprofen or Tylenol, physicians will often turn to prescription-strength narcotic analgesics. Many of these drugs are in the opioid category that can be highly addictive and need to be monitored closely to keep addiction from occurring. Narcotic analgesics are used for their ability to manage pain, and they come from opium and their derivatives such as codeine, morphine, and methadone. They can be highly addictive and allows athletes to play through an injury or mask an injury, meaning that it diminishes the sensation, the effect of pain, allowing you to play through the pain. Some common analgesics are pain-relieving agents. Morphine is the most common analgesic component of the opium poppy. The morphine potency can be significantly enhanced by acetylation to diamorphine or heroin. Codeine has only 1/5 the potency of morphine, but is absorbed into the GI system easier. So here we see just some Information on opiates. Opium, morphine, codeine, and theanine are refined directly from the milk of the opium poppy. Some opioids, such as heroin, oxycodone, are semi-synthetic, which means that they are a refinement of the opium poppy and is manipulated in a laboratory. Synthetic opioids include methadone, Demerol, and Darvon. Here we take a look at a slide that shows some of the effects of opioids and opiates. Other therapeutic effects include cough suppression and diarrhea control. The higher euphoria or the euphoria produced by these drugs often leads to unwanted side effects. Euphoria can be very pronounced with drugs such as heroin. Narcotics are medications that help impact and decrease the pain levels of the people that take them. The main neuroreceptors for pain are called nociceptors. They help the body to perceive harmful stimuli. Our Drugs and Sport text discusses the subjectivity of pain and the differences between pain and nociception. Narcotics can essentially change our perception of pain, but not necessarily the harm of the pain itself. So here we see a diagram of a synapse, and it illustrates how a pain signal is transmitted through the nervous system and causes a secondary terminal to release endorphins that then slot into the receptor sites on the primary terminal and limit the release of the pain neurotransmitter substance P. Heroin or any opioid can slot into the secondary endorphin receptor site, limiting the release of substance P that gets through. By slotting into the primary substance P receptor sites on the receiving dendrite of the next neuron. Here we see that law enforcement as well as treatment personnel can get a strong indication of drug use of people by the size of their pupils. Opioids, especially heroin, constrict your pupils, and methamphetamine, ecstasy, and cocaine and stimulates dilate the pupils. The withdrawal symptoms from chronic opioid use can be extremely uncomfortable and painful. Withdrawal is almost never fatal, but users just feel like they want to die. The pain of withdrawal is one of the main reasons for relapse. Some medications can be used to temper the discomfort of withdrawal. So here we see various routes of transmission of narcotic analgesics: orally, by mouth, intravenously into the vein, usually by way of a needle, or injection, which is under the skin and into the muscles. So narcotic analgesics are more powerful and more addictive than nonsteroidal anti-inflammatory drugs, and therefore can be a greater problem for athletes when their playing days are over and their painful muscles and joints persist. Now we're going to turn our attention over to cycling. Cycle races such as the Tour de France, Amgen Tour of California, and just cycling in general has been a very, well, to say the least, a dirty sport and plagued by drug use. So we see here, especially the last 20 years, has been really a time to try to clean up that sport. A pot belge is a French term that is used to describe a mixture of drugs illegally used by cyclists. It can be translated as a Belgian mix or a Belgian stew, and English sources have sometimes used the term Belgian pot. So we see here in 2004 there was a major case involving a number of teams that had a lot of drug use and using this pot belge common term. And cycling has been the subject of narcotic abuse, and long-distance cycling requires overcoming pain barriers. Each day, the cyclists ride over 100 miles on many of the races with elevation, and it's basically like doing a marathon for over 20 days in a row. So the athletes are going to do whatever they need to continue competing. As we look and see here, the differences between psychological dependence and physical dependence. Dependence is a condition where the user can have a psychological or physical need for a substance. Psychological dependence is characterized by having a continued craving or desire for a substance, and physical dependence is shown when withdrawal symptoms are experienced after a person stops taking that substance. Tolerance is the need for an increased dose of the drug to produce the same pharmacological effect. Here we see some adverse effects of narcotic analgesics. They increase the pain threshold and allow athletes to ignore their harmful pain. They mask injuries to play through their injuries, and they risk further injuries. It's often been the topic of some very legendary and heroic sports moments where players play through their injuries, risking further injury, but achieve glory on the field. From Kirk Gibson's dramatic ninth-inning home run in the 1988 World Series off of Dennis Eckersley that coined the phrase walk-off home run, to Willis Reed returning to the Madison Square Garden to upset Wilt and Jerry's Lakers in the 1970s after sustaining a leg and back injury, to Paul Pierce being carried off the Boston Garden floor only to return and lead his team to victory. Curt Schilling's bloody sock and injured players have captured the admiration and imagination of fans and sports writers alike who are anxious to create a hero out of a sports situation. Here we see in equestrian sports. In 2002, the horse Be My Royal tested positive for morphine in an effort to get the horse to race through their pain. So instead of steroids or other performance-enhancing substances, this horse was given narcotic analgesics to run through the pain that the horse was experiencing. Even with a lack of scientific evidence that shows any legitimate advantage in performance enhancement, analgesics are banned because intuitively it would seem like an advantage to perform while taking a medication that potentially allows you to play through pain and perform better. Unfortunately, these medications can take away the protective mechanism that pain provides that self-limits us from pushing ourselves so hard that we are causing further injury. There are a number of legitimate therapeutic uses for narcotic analgesics, including treatment of cough, diarrhea, and pain relief. So here we see the side effects of non-steroidal anti-inflammatory drugs over the counter. They're used for numerous reasons and range from the more common, like getting an upset stomach or GI upset, to even paranoia and confusion. Drug companies must label a side effect even if a small percentage of those who have taken the drug may have experienced them. So let's now turn our attention to the World Anti-Doping Agency. This slide shows the low incidence and the presence of the narcotics used and found during random athlete drug testing. WADA is perhaps the most influential governing body in establishing and determining which substances and how much of them are considered performance-enhancing or harmful. They review these, and different substances end up on the banned list from year to year. And it is up to the athlete to know which substances they're taking and which if there's any banned substances in the supplements that they are taking. So we're going to turn our attention now to masking agents and diuretics. So we see here diuretics are often used for weight management. Any sport where making weight is a prerequisite for participation, such as boxing, wrestling, jockeys and horse racing is preferred, and weightlifting has different weight classes. So a masking agent they're basically drugs that don't possess any performance enhancing properties, but they're used to help you urinate or eliminate any banned substances that might be in your system. So diuretics are commonly used for this.
Diuretics are what we commonly call water pills. What a diuretic is any agent that acts to increase urine. In clinical conditions like high blood pressure, heart failure, renal failure, or nephrotic syndrome, they are used to adjust the volume or the composition of the fluid in the body. They also increase the excretion of water and electrolytes from the body's fluids, and by doing so, they decrease the fluid volume. There are 5 major classes of these drugs. Diuretics are sometimes used in sports and in bodybuilding. In sports, they are called masking agents. They don't enhance performance in any way, but instead they are used to mask the presence of other banned substances in the body. There are other examples of masking agents besides diuretics, and they all work in their own way, but the basic goal is to either reduce the concentration of an illegal doping agent or its metabolites in the urine. This is done in hopes of making the detection of these things in the urine more difficult. As you could guess, diuretics have been banned by the World Anti-Doping Agency since 1988. As masking agents, diuretics may not work very well. First, the diuretics themselves can be detected in the urine, and diluted urine can simply be concentrated and the pH adjusted before being tested. Now, they are not only used as masking agents in sports, they are also sometimes used, such as in boxing and wrestling, to quickly drop weight to meet a weight requirement. This isn't legal either, and it is very dangerous. In bodybuilding, diuretics might be used to help get the very detailed, ripped and shredded appearance that bodybuilding judges look for. See, no matter how low your body fat percentage, your skin still has a bit of water underneath it. This is going to hide some of the detail of the muscles. Diuretics can shed excess water and so make the skin thinner, and then every little detail, every little striation and vein can pop out in bold relief. This is called drying out. Again, it can be dangerous. Certain diuretics, like the commonly known Lasix or furosemide, are too potent and not only dry out the skin, but they can dry out the muscles as well, making the bodybuilder look deflated. And their potassium depleting effects may not be something to play around with, so potassium sparing diuretics are preferred. Some bodybuilders use herbal diuretics like dandelion, which anybody can get over the counter, and bodybuilding supplement companies make herbal preparations which contain a mixture of diuretic herbs and extra magnesium, calcium, and potassium.
So as we see here, diuretics do produce copious amounts of urine with the goal of excreting the presence of prohibited substance out of the athlete's system through urination or excretion. It has also been connected with the treatment of altitude sickness, but with this purpose in terms of drugs and athletics, it's typically used to mask the use of other drugs by excreting it out of the body. So we see here that diuretics are commonly used in bodybuilding to help counter the fluid retentive properties of anabolic steroids. They help the athlete attain that cut look, which is important for competition. If you have a therapeutic use exemption that allows you to use a diuretic, but a banned substance is then found in your system, the use of diuretics is no longer valid. So let's review, take a look at some of the questions that and the topics that we've covered in this lecture thus far. The drugs commonly used to mask the use of other illegal drugs are called diuretics. The use of diuretics can lead to weight gain, fluid retention, decreased urination, or cramping and dehydration. So diuretics can lead to cramping and dehydration because you're excreting and urinating more. Blank is the need for an increased dose of the drug to produce the same pharmacological effect, and we see that's either adaptation, adjustment, tolerance, or habituation, and the answer there is tolerance. A key neurotransmitter involved in pain transmission is known as substance P, and that is right. Blank is characterized by the continued desire or craving for a substance, being physical dependent, addictive personality, a hunkering, a psychological dependence. The answer would be psychological dependence. So the inflammatory response, mast cells release histamine that causes vasodilation of the capillaries. That would also occur. The first discovered non-steroidal anti-inflammatory drug was Tylenol, ibuprofen, aspirin, or Alka-Seltzer. And there we see it as acetyl salicylic acid or aspirin. Masking agents have anabolic properties. That is not true. They act as masking agents. They're diuretics. They cause the body to urinate and excrete out the substances that they're trying to mask. Blank is observed when the substance is no longer administered or used and physical withdrawal symptoms are experienced. Psychological dependence, unwithdrawal, catharsis, or physical dependence? And the answer is physical dependence. Remember to check your university email daily for any important announcements regarding this class. Log on to the course Blackboard page daily to check for assignment guidelines, calendaring your due dates, and checking your updated grades. And please note that our text Drugs and Sports 6th edition is available for 2-hour checkout at the Stanislaus State Library. Thank you very much.